here, and I'm going to touch about fiducial placement and the EUS guidance, which is for SBRT, or it is stereotactic body radiation therapy, or some other groups say stereotactic radiosurgery, SLS. SBRT is a emerging radiation method to deliver high dose radiation to the target, either single dose radiation or small number of fractions. So it requires high degree of precision. So to achieve that, we are going frequently insert metallic markers, which is called as fiduciaries. And SBRT indications are becoming larger and larger. Lung cancer can be one of the target, HCC, prostate cancer, and also pancreatic cancer is one of the target. Traditionally, it was inserted by under ultrasound guidance or CT guidance. So most of the fiduciaries were inserted by interventional radiologists. But deeper portions such as deep pancreas, uncinate, or caudate lobe of the liver, it is not easily accessible by ultrasound guidance. So would be better to use EUS, because when we insert the EUS scope, the caudate lobe is very close to the stomach and just within 5 millimeter distance. So EUS-guided placement have the advantage to reaching the deeper portion lesions. Luckily, there are variable sized fiduciaries available. The smallest one can go inside a 19 gauge needle. So, and the other, this is Cook Company, a multiple fiducial insertion device, marked needle device. But unfortunately, this needle is not available in Korea. Or some of the Korean stent making company try to develop these platinum fiduciaries, but still not on the market. So we are using fiducial markers which is designed to be used for percutaneous purpose. The first report about fiducial insertion was in 2006 for mediastinal or abdominal malignancy. These groups actually inserted several fiduciaries under EUS guidance. So feasibility, technical feasibility is already shown by this this article. When we use fiducial markers on the EUS, because it is not designed for EUS guidance, so we need to insert bankloading technique is required. At the tip of 19 gauge needle, we can insert fiduciaries. And after removal of the stylet, we can insert it. And to keep the stability, we can add bone wax to seal the tip of the needle and the fiduciaries. This video shows how we insert fiducial markers. This is 19 gauge needle. After the removal of the stylet, we are trying to make some the opening a bit larger by the stylet, and then the small fiduciaries can be mounted at the tip of the 19 gauge needle. If you have dedicated device, all these steps are actually unnecessary. But at the current moment, inside Korea, there is no dedicated device available. So we can insert the fiducial markers inside the 19 gauge needle, like this. And then, because sometimes during the insertion into the instrumental channel, the fiducial markers can be moved or migrated. So to keep the fiducial markers in the tight position, we are using bone wax to seal up the space. And then on the EUS guide, okay. Then we can use this fiducial marker for insertion for this kind of borderline resectable pancreatic cancer. This is the EUS view. Main pancreatic duct is dilated, and the downstream here there is mass. but we can insert fiducial markers inside the tumor or near the tumor, alongside of the tumor. Then the radiation oncologist can calculate the ideal target location based on three-dimensional distance. The first fiducials are inserted into the pancreatic parenchyma here, and then change the location and insert another one. This is fluoroscopic view showing EUS-guided fiducial placement. The first fiducial is going inside the pancreatic tumor. After needle insertion, we can push the stylet. Then the tightly impacted fiducial markers can go into the tissue. This is first fiducial. And then remove the needle and the stylet and bang load another fiducial, and then try to target different areas. So we can, most of the times we use 3 fiducials for the targeting of a single tumor. This is second fiducial, and the third one around this area. This is, I will show you some case. The 73-year-old gentleman admitted because of epigastric pain and jaundice, and CT scan shows mass in the head of the pancreas, but because of obstructive jaundice, we did insert plastic stent and then try to do neoadjuvant therapy because it was so-called borderline resectable case. So gemcitabine Taceba chemotherapy was performed 1 cycle, and then we inserted fiducial markers, and based on this, CT simulation was done. The radiation oncologist can target the lesion 3-dimensionally. And then after 4 fractions of SBRT, gemcitabine Taceba chemotherapy continued until 6th cycle. And then we can see the marked decrease of the tumor here. And there seems to be some distance between the SMV portal vein and the IVC line and the tumor. So this patient was sent to surgery, PPPD was done, and the resection margin was free. So it was quite a successful case. This is another case, pancreas head cancer. Geloda gemcitabine chemotherapy was done 3 cycles, but the tumor showed progression. So chemo itself, chemo only, seems not very sufficient. So we inserted the fiducial markers under EUS guidance and did the SBRT, and after that we can see marked size shrinkage. I cannot say this is complete cure, but we can control the disease, we can create partial response. And also this technique can be used hepatocellular carcinoma case. This is a 58-year-old female HB virus associated LC. During the follow-up period, we can see low attenuation area in the caudate lobe here. It's very small. When we did angiography, there was no tumor blush, but this lesion was quite suspicious. So we did EUS-guided FNA, and the FNA shows HCC with fatty degeneration. Because of that, we can see a bit higher echogenicity, but the treatment was difficult. TAC is not working, and surgery is not a good option for this kind of advanced LC. So we inserted 2 fiducial markers, upper part and lower part of the lesion, and did SBRT. Now we can see progressive size decrease. So if we use this technique, we can help some group of patients. When we analyze our group, 67 patients, the indications were pancreatic cancer, or HCC, or cholangiocarcinoma. And the location of the tumor is pancreas head, body, and tail. Most of the areas can be reached by EUS. And the complication rate was negligible, but migration rate was quite high, 10%, about 10%. So our conclusion was fiducial placement under EUS guidance is technically feasible technique for preparation of patient with pancreatic or hepatic malignancy. But there were some migration issues. But if you see this kind of different design fiducials, This is coiled fiducial. So if we insert this design, then it is coiled inside the tumor. So there seems to be less risk of migration. Or this kind of design, when we inject into the tissue, then it can be folded like this inside the tissue. Then the migration rate will be much, much less. When we review the reported literature until now, this technique is used for various indications: esophageal cancer, and gastric cancer, and pancreatic cancer, and rectal cancer, and some other indications. Among the more than 500 cases, the technical success was almost 99%, approaching almost 100%. The migration rate is quite low in this group, in this group's report. Adverse event is quite low. Until now, there are various types of fiducial markers are used. Gold marker, or busy coil, or newly designed the Cook preloaded fiducial. These are not very popular, but some groups are using these markers for SBRT. Technical success ranges from 85% to 100%, and the complication is very small. So, and also we can use this technique for the prostate cancer. Prostate is located very close to the rectum, so if you insert the echoendoscope through anus, then it will be reached within 10 cm distance of insertion. Then we can insert fiducial markers for radiation therapy. Or some group used this technique to help the surgeon's pancreatic surgery, parenchymal sparing pancreatic surgery. But I'm not sure whether this technique can become popular. But anyway, fiducial can guide the location, finding the location of small pancreatic tumor. So this is my final conclusion slide. EUS-guided fiducial placement for SBRT in pancreatic or hepatic malignancy appears to be safe and feasible technique. Fiducial placement represents another application of interventional EUS and potentially expands the indication of SBRT by accessing anatomic structures that may have been otherwise inaccessible. Thank you for your kind attention.